I'm really delighted that you've joined us today. We've got a really packed agenda and a really exciting agenda, but I'd like to make special thanks to Sunil Malhotra and Meena Arun, who have produced the agenda and invited speakers, so it's made a really interesting session. We just move on and just go through some very quick housekeeping rules. We all know the etiquette of Teams now, so please do stay on mute unless you're speaking. We were trying to build in a dedicated question and answer session after each of the presentations, but our timing is quite tight today. So if we could ask you to put any questions you may have into the chat box, if we can accommodate them at the end of each speaker, we will do. And if not, we're going to collate those questions. We'll send some answers around afterwards so that people can have their questions answered. So please just do pop them in the chat. We're also monitoring the chat function as well. So if you have any comments throughout the meeting, you'd be really welcome to put them in. And we obviously record the webinar because not everyone is able to join us at the session. And so this is then distributed widely to our members so that people have a chance to watch it afterwards as well. And we'll send everybody a link with the recording and all the slides after the session. Okay, so as I say, our agenda is an exciting one and quite tight. So you can see there, we'll introduce everybody individually, but we're going to think about our paediatric workforce, our advanced clinical practice in paediatric ophthalmology, some of the case studies about the clinical impact of the role of the ACP, and then moving on to some digital and technological advances around consultations, handheld fundus cameras, and also using artificial intelligence as well. So we've got a lot to pack in our hour and a half. Just like to also refer you to the upcoming events as well. And you can see there that from the next one is on Friday, the 21st of April, and that's being led by Mary Freeman, who is also a UKOA board member. And then we have some other dates for your diaries as well. And again, they're always sent out well in advance to everybody. So I think without further ado, what I'd like to do is give a warm welcome to Sus Biswas, who's a consultant paediatric ophthalmologist at Manchester Royal Eye Hospital and chair of the paediatric subcommittee of the Royal College of Ophthalmologists. And Sus is going to talk to us about the overview of the current paediatric ophthalmology workforce. So over to you, Sus.
Thank you, Veronica. Thanks for inviting me, and thanks to UKOA for inviting me. So I'm going to be talking about the paediatric workforce. So if we can move forward a slide. So I'll outline the problem, what's being done now, what are the barriers to improving the situation, and what needs to be done in the future. So we can move forward another slide. So by way of introduction, what are the problems? Well, we are aware that there are often vacancies which are hard to fill in paediatric ophthalmology. This may be due to retirements, or maybe due to a change in demand, or an increase in or a decrease in capacity. Of course, paediatric ophthalmology has to compete with many other specialties in attracting trainees in ophthalmology, as well as other professionals involved in the care of paediatric patients like optometrists, etc. Also, there may be issues around trusts changing their overall strategy with regard to paediatrics, and paediatrics can be quite a challenge to do, and unless you're a children's hospital, actually having the correct specifications and stipulations to comply with national service frameworks can be quite a challenge. And of course, part of that challenge may involve having enough physical space and resources in order to carry out your activity. So if we can move forward another slide. So I'll just present a sort of case example in mind. So we can move forward another slide, please. So I was contacted in 2019 by a consultant, rather desperate, in a large children's hospital where they had trainees withdrawn because of the lack of a stable workforce. So that consultant had been drafted in, and he had two remits. One was to attract more consultants, and the second was to reinstate the trainees. Now, that was a bit of a chicken and egg situation, because it's hard to attract consultants when you don't have trainees, And of course, it's hard to attract trainees when there are no stable consultants in the workforce. So was this an isolated problem? So we can move forward another slide. So I'm grateful to Margot Campbell, who's a developmental paediatrician in Scotland, and Kilmaine, a paediatric ophthalmologist working in Scotland as well, for providing me with some data around a survey of their workforce. Now, this is principally around the visual impairment in children and young persons in Scotland, but they also appended onto that some metrics around workforce provision. Now, they had 14 centres respond. 2 designated themselves as a tertiary referral centre, 9 designated themselves as secondary, and 3 didn't answer the question. But actually, looking at the referral patterns, around 6 centres would probably be classified as tertiary referrals, having received referrals from surrounding smaller units. Now, looking at the number of centres with more than one, or at least one, whole-time equivalent consultant paediatric ophthalmologist, 8 out of the 14 centres had that, whereas there were 4 centres that had less than one whole-time consultant paediatric ophthalmologist, and 1 centre had no whole-time paediatric ophthalmologist, despite providing paediatric ophthalmology services, and they were very much reliant on locum provision. So we can move forward a slide. So again, looking at that survey, one of the questions was, did they feel their capacity in the clinic was sufficient to deal with the workload? And as you can see, the majority felt that their clinical capacity, in other words, space or number of consultant sessions, was insufficient. And only 1 centre felt it was sufficient, with a few not answering. Move forward a slide, please. And the number of centres with that were concerned about consultants retiring were variable. There were 3 centres that had a definite concern, and then there were 6 other centres where there was possible concern about retiring consultants. But it was a little bit unclear because of the way the questions were phrased as to whether these were solely paediatric ophthalmologists or others. If we can move forward a slide. Now, in terms of recruiting, and this is the big issue, there were a number of centres where they had stated difficulties in recruiting to the consultant workforce. So there were 7 altogether, and of those, there were 4 that were what I'd consider to be major providers of paediatric ophthalmology. And then there were a few centres as well that felt that they didn't have any major concerns with regard to recruiting, 6 overall, including 1 major provider. Next slide, please. So how can we meet the challenge? And unlike this tree, bearing plenty of apples, ophthalmologists don't grow like that. So can we move forward a slide? So now we could have done a survey ourselves, but I think we sort of decided that perhaps there were dangers of doing a survey, in that maybe the questions that were asked may be misinterpreted or answered in different ways by different people. So instead, what we thought about was whether we should set up some focus groups to look at what's being done, what are the concerns, essentially to carry out some form of qualitative analysis of the state of play and what people felt could be done in the future to improve recruitment and capacity and activity. So we sent out invites through the paediatric list server, and we got responses from 17 paediatric ophthalmologists who wished to take part. They were a mix of consultants in tertiary referral centres and district general hospitals. And then there were 10 orthoptists involved, 1 optometrist dialed in, and we had 2 ophthalmic trainees. We also had a commissioner actually dial in as well to this. So we can move forward a slide, please. So we undertook 4 sessions. We designated 4 sessions with the aim to establish what the scale of the problem was and what the possible solutions could be, which had been shared through various people's experiences. We wanted to look at how people were managing their waiting list and workload, and particularly the risks around waiting list management. We wanted to examine any new ways of working and what strategies people were adopting to deal with the demand with their limited capacity in many cases. And we also wanted to look at training, recruitment and retention, and in particular what ideas people had about improving uptake in paediatric ophthalmology from trainees and how we can try and retain the workforce. And then there were these were all tied up in a summary where we looked at the themes that were discussed and the items that were most discussed and what possible outputs we might have in order to try and create a strategy that the Royal College could adopt. So if we can move forward a slide. So these were the things that were most discussed during the focus group. So there was a heavy utilization of advanced care practitioners, optometrists and orthoptists to meet waiting list demands, and those individuals were doing new and extended roles in the outpatient services. There was also a concern around the lack of trainee paediatric ophthalmologists, which was considered to be a long-term threat to the stability of the subspecialty. We were also looking at whether the new ways of working that came around during the COVID-19 pandemic were still being utilized. Were they sustained? Was there any new ways of doing that? And also looking at new ways of working whilst meeting the immediate challenges of patients sat on a waiting list for an extended period of time and what impact that had on that. So we discussed a number of solutions, including upskilling the workforce, development of advanced care practitioners, extending roles of optometrists and orthoptists to take on a more prominent role to tackle backlogs. And this may in its turn open up new pipelines for referral of patients to the ophthalmologist. We also explored some concepts about how to make pediatric ophthalmology more attractive to trainees, and we wanted to see what new ways of working could be embedded, such as risk stratification and clinics with parallel running orthoptic and optometric-led services. If we can move forward a slide. So the outputs were suggested were broken down into three main categories, and the first category being what actions could be readily implemented, in other words, straight away with minimal change, what strategies could be adopted, but they do require a little bit of investment and funding and development, and longer term strategies which may require a national strategy and changes in the way that the college work and also legislative changes. So of those actions that could be readily implemented, one useful strategy was obviously to continue the risk stratification that started during the COVID-19 pandemic, and this proved to be quite a useful way of identifying high-risk patients off the waiting list, and provided that these patients could be seen quickly and managed, that could deal with the immediate issue of risk. The judicious use of telephone, video consultations and telemedical programs, as well as the creation of in-mail inboxes, was discussed by a number of groups that were implementing this still. I say judicious because there was still some concern over the safety, particularly around measuring visual acuities. And then this new concept that's come through the NHS outpatient transformation program of patient-initiated follow-up. This really hasn't been well developed in ophthalmology in general, but could be an opportunity of managing patients on the waiting list and eventually removing them. Medium-term strategies do include, and I know this is a subject of the later talk, or the development of advanced care practitioners, but also the development of the existing skilled SAS workforce who may be underutilized in this respect. The discussions around cross-site working and hub and spoke models was also felt to be a potential medium-term solution, and also looking at how consultant job plans could make them more attractive to potential candidates for open vacant posts. And then the longer-term strategic planning involved changing the training culture around paediatric ophthalmology to make it less scary and more welcoming and more enjoyable. And then in the enhancement of other professionals in their capacity to undertake independently running clinics, such as independent prescribing for optometrists and refraction capability for orthoptists to be enhanced. Can we move forward a slide? So in summary, we felt this could produce some form of output, some form of document briefing from the Royal College of Ophthalmologists, which would report the state of paediatric ophthalmology and which would be combined with discussions with data from the workforce census project that's been carried out by the college. And this might feed into a national action plan to improve the state of paediatric ophthalmology workforce. And we can, of course, have a combined approach with UKOA to raise the awareness of practical approaches to assist trusts in tackling their waiting list pressures for paediatric ophthalmology. Thank you. Next slide. And that's it. Happy to take any questions if there are any.
Thanks so much, Sus. That was really, really interesting. And we have got a question from Penelope that's come through in the chat, which I think we can take quickly, about why nurses were not considered in the strategic planning rounds.
Yeah, I mean, it's a good point. I think that anyone within the workforce can be considered. I think one of the challenges that we have is around paediatric nursing. And that's where we need to recruit from, and that can be quite difficult to get. So I mean, the vast majority within our hospital, the vast majority of nurses are involved in ophthalmology are adult oriented, and very few, and we've struggled actually in a big children's hospital to get paediatric nursing involved. And I think that has been a bit of a barrier.
Okay, thanks. So I think there's some more comments coming through in the chat. Mel has just said in a lot of PEDS clinics, the nurses have been removed as the managers think we don't need them, as we have orthoptists and we're not the same professions and we do very, very different things. So yes, that's an interesting thought.
I agree.
Sharon, and Sharon in the chat has also said Wales seems to be moving to include other healthcare providers, particularly optometrists for medical retina and glaucoma. Was any of that sort of included in this work? Alongside another comment around suggestions of the role for primary care optometrists. I think there's quite a theme coming through there. Didn't know if you wanted to comment quickly on that, Sus, or?
Yeah, I mean, we had a commissioner involved in one of our focus groups, and it wasn't really, as I said, this was really a focus group discussion. So whatever came up and whatever themes arose were sort of focused in on. But I think there is a potential role for primary care in an escape route for patients or a way of keeping patients out of hospital. But again, this needs a much wider discussion, and it's not a short-term strategy. It's probably a longer-term strategy, but one that should be grasped, I feel.
Thanks very much, Sus. That's great. As we said, we're capturing these comments and questions in the chat as well, and we will get to any that we don't manage to come to on the day. So thank you, Sus. I'm delighted to introduce Dr. Charlotte Cadena, who is the Senior Lecturer in Orthoptics and the Programme Lead for the ACP, or the Advanced Clinical Practice Masters in Paediatric Ophthalmology at University of Sheffield. And I'd like to hand over to Charlotte. She's going to introduce this to us. Thanks, Charlotte.
Thank you. Thanks, Veronica, and thanks for the great previous talks. It's wonderful to be with you this afternoon and to have this opportunity to tell you a little bit more about this programme that we started just almost 2 years ago in 2021. If we can go, thank you. We had our first intake in 2021, and we've now got first-year students, second-year students, and we're recruiting for a third intake, which will begin this September. So I think Sus has already explained the difficulty that we're facing, and I'm sure everybody on this call is well aware of our capacity and demand difficulties in paediatric ophthalmology. And in response to this, Health Education England commissioned this programme, and we have been developing it to try to really meet the needs, which I'll explain a little bit about that. So I think we're all aware that we have this big shortage of paediatric ophthalmologists in the UK, and in wider ophthalmology we continue to be the busiest specialty, and I regularly meet with people who are feeling the pressures in the ophthalmology service. So to tell you a little bit more about advanced clinical practice, the Health Education England have the Centre for Advancing Practice, which is in the process of accrediting programmes, and they have opened to portfolio routes to allow people who might have had their experience in slightly different ways to apply to be advanced clinical practitioners. So it really revolves around these 4 pillars, and we've set our programme up to really embody these pillars. So in our first year, we have a real clinical emphasis because we feel that the students really need to step into paediatric ophthalmology clinical advanced practice. And then we cover the rest of the pillars in the second and third year, which I can explain a little bit more about in a coming slide. So when we were approached by Health Education England in regards to this programme, we really wanted to know what would be most useful in terms of the capacity and the demand situation. So we put out a survey, which some of you might have kindly participated in for us, asking ophthalmologists what areas of your practice would you really appreciate some support from an advanced clinical practitioner. We went to ophthalmic nurses, to optometrists and to orthoptists, because those are the professions that our programme can recruit from. And we went to those practitioners to say, what areas of your practice do you think you could upskill in to take on the work of an advanced clinical practitioner? And then we looked at and had conversations with several paediatric ophthalmologists as to what conditions were very clinically burdensome in terms of clinic lists. And we looked at where there was a convergence between all of these different factors, and then we looked to incorporate those into our curriculum. And so this is what we came up with. This is our first year foundational core module in paediatric ophthalmology. And these are the different areas of clinical practice that we've concentrated on due to the process that we went through, as I just explained. We are probably going to be expanding this in the coming years and allowing our students to pick from 20 of these to most meet their service needs, because we recognise that our students come from quite different hospitals. So we've got, students in very large hospitals, some in smaller, more rural settings, and we realise that there is a bit of a difference in what in the kind of package that students needs. So all of our students have a mentor. Usually a paediatric ophthalmologist, plus they may have additional local mentors for some of these areas. And each one of these subject areas is given to the students as teaching material. And I think you're going to hear from some of our students later, so they can tell you a bit more about it. And they require the students to undertake some learning, some independent learning, some online learning, and then to carry out some clinical activities with the support of their local mentor in their place of work with work-based learning. And then those things are assessed with contributions from their local mentor throughout the programme. So as our students have come onto the programme, they've often had extended roles. So they might have, for example, done lots of retinal imaging and worked in JIA screening in an extended role clinic, for example, or they might have done low vision, but very few of our students, well, none of our students have actually had this very broad area of practice. But I guess the advantage to this is we're a completely online programme, and our students come from all over the UK and actually have quite different areas of expertise. So it's a really great way that they can share with each other, and I love seeing them share their learning, where they're saying, well, I do this extended role, or I do this extended role, and are happy to share some of their learning and case studies that they've collected with other students on the course. So our first year is a big bulky module in paediatric ophthalmology, and students can just take this first year actually. That leads to a PG cert. Then with our second year, we move to another compulsory module, which is clinical leadership and education in ophthalmology. So that's a new module looking at specifically some of the needs and some of the roles that ACPs would most helpfully take in trying to streamline some of our clinical pathways, in thinking about holistic working, or in sort of bridging the gap between the traditional profession-specific boundaries that might have emerged. So then they get a choice. They can either take research methods, which then would most likely lead to a clinical research project, and we're really excited that our first students will be starting to do that this September. Or they could take exemptions to be able to supply medicines, or they might specialise in low vision, and they might go on to a literature-based dissertation as their final year project. So we do offer some flexibility based on the things that the students most need out of the course and on what their service most needs out of the course. So our second years, who I think you're going to hear from, are towards the end of this module, and we're really looking at, in this module, what effective clinical leadership looks like in ophthalmology, what the difference it could make, and there's a growing breadth of literature showing how it can positively impact patient care. And one of the things that we're specifically looking for is how to release clinical capacity and how to make the most of the workforce and models of transformational change. So really excited to see how that will progress. And there are some key things about advanced clinical practice that I've already mentioned, things like streamlining and modernising patient pathways, looking for an effective sharing of skills across traditional professional boundaries, looking at holistic working, increasing their scope of practice. So these things will be really useful for us in paediatric ophthalmology. And I guess the benefits that we hope for and that we're already starting to see is that many conditions which are seen currently by ophthalmologists can be effectively handled by ACPs, which can free up ophthalmologist clinical time and workload for the more complex cases. We hope that this will be able to help with the clinical capacity. We want to decrease the burden on our ophthalmologist colleagues, and we hope that this will have a really positive effect actually on recruitment and retainment, which we know has been a problem for some of the professions that I mentioned earlier, in terms of recruiting and retaining orthoptists and optometrists, and we have some good research to show that having a very clear career pathway actually helps with those things. So where will it lead? I guess we are still working that out, and we do recognise that there is an overlap in the work that we all do, and a necessary overlap. And we just hope that these advanced clinical practitioners can really provide a workforce solution that takes some of this workload in this middle space here. So I said that we were open to ophthalmic nurses, orthoptists and optometrists. Most of our students on the course are actually orthoptists, so hence moving in this direction, but we are increasingly getting more inquiries from ophthalmic nurses, which is great. And I think just recognising that these practitioners have got great skills in assessing children already, which leads them to be really good candidates for taking those skills a little bit further and using those on other pieces of equipment like the slit lamp. So I've got a few quotes, and I'm sure you'll hear more from our students, but they found it very interesting so far, educational, exciting. There have been feelings of overwhelm, but then growing confidence to meet that. And one thing that really I'm pleased with is that the students can see the impact and the potential further impact of their trainee ACP clinics. So we hope that the impact will look something like this, with there being other people to take up some of the workload in these areas, running simultaneous clinics, perhaps providing additional clinics if there hasn't been a specific screening clinic, for example. And we're working very closely with Health Education England and our partners in the regional faculties for advancing practice. So there's 7 different faculties, and we're in the process of making our course known to each of those. And we've got students from all over the UK, which is really exciting. There is financial support, so Health Education England are funding the majority of students on our courses, and we do have an agreement with them that whilst we're not open to an apprenticeship yet, we are working towards that with the University of Sheffield, but that where no such course exists as an apprenticeship, they will fund a standard route. So most of our students are funded by Health Education England for the duration of the programme and go on to get their Masters in Advanced Clinical Practice in Paediatric Ophthalmology as a result. So we're grateful to our mentors, our local paediatric ophthalmologists, who are carrying out some of the work-based learning and the reflective discussions with our students, and they have access to a handbook which tells them the process that the students will be going through. And I know many of our students are deeply grateful for their mentor support, and Health Education England are also providing some training for supervisors in this respect as well. So we very much value the impact, and the work-based learning is a really key aspect of the course. My informal feedback that I have so far is that ophthalmologists are appreciating that a lot of the training is given centrally, and so the students are coming with a lot of education already behind them when they come to meet their mentors. So we hope that the new programme will lead to an increased workforce and a more distributed workload. We hope that it will have really exciting new and clearer career pathways, which we hope will help our retention for eye care practitioners. And we hope that it will result in improved access to and more responsive care for our patients. We hope that this opportunity that advanced clinical practice brings to muddy the waters between the profession-specific boundaries will be beneficial for all of us, actually, and lead to these clearer pathways for patients. And obviously we do need to factor this into our workforce planning, because we don't want to steal everybody away to advanced clinical practice in terms of our national picture. So I hope that's been a helpful brief tour of the programme, and I'm very happy to take questions. Oh, I think I can see some.
Much, Charlotte. I know, Charlotte, that was brilliant. Thank you so much. And we have got some questions in the chat, but I just wonder, just in the interest of time, if we listen to your students on the ACP course, and then if we've got an opportunity to take those questions together, we will do at the end, if that's okay, Charlotte. Yeah, so it's a pleasure then to introduce Christina McMahon, who's an orthoptist from Oxford, and she's going to be talking to us about implementing an ACP-led clinic in paediatric ophthalmology. So over to you, Christina.
Thank you so much, and thank you so much for asking me to speak. This is just going to be a little bit of an audit of how my clinic, or the clinic that we've been implementing so far, has gone. It's still very early stages, but just to get an idea of how the clinic runs as a trainee ACP. So I'm going to go over the rationale, which we've obviously heard, the patient cohorts involved, current data that we've collected so far, the challenges that we've come across, and what we're looking forward to in the future. So if we could go on to the next slide, please. Perfect. So the rationale has been explained brilliantly already, but just to say, in our department in Oxford, it's really been felt that the current demand for paediatric ophthalmology is above capacity, and the routine wait list is currently at 6 months. So we are really desperate to try and reduce that wait list time. And hopefully this ACP clinic can help relieve the pressure of the consultant. So if we go on to the next slide. Thank you. So the patient cohort that we've been focusing on primarily is anterior segment. So currently these are the diagnoses that are triaged to the clinic and that are accepted into the clinic. So we've got allergic conjunctivitis, VKC, blepharitis, chalazion, epiphora, and nasolacrimal duct obstruction, and then dry eye disease. If we go on to the next slide, just a little bit about the posterior segment patient cohort. We are implementing this. This is in a separate clinic, and that's because of the reliance that we have on imaging services and on visual fields. So we are running a suspicious optic disc clinic, both new and follow-ups, and we also have a paediatric neuro-oncology centre in Oxford, and so we see those as part of this clinic as well. I won't be speaking in too much detail on this because it's run by my colleagues, but this is something that we're implementing as well. And if we go into the next one. Lovely. So this is just to show sort of how we go from the base profession to seeing the patients in this clinic. So working on the theory from the clinical module from the university course, building up those practical skills, lots of observation of experienced staff, and then multiple case collections, lots of reflections and own research. And then once that's confident, moving on to assessing patients, being observed by the consultant, having those competencies signed off, building the SOPs, and then finally seeing those patients independently in the ACP clinic. So whilst those diagnoses that I mentioned previously, we're at that point where I'm seeing those patients independently in the ACP clinic, there are still more diagnoses that are maybe in stage 2 or where we're still kind of building those SOPs for them to be involved in the clinic. And hopefully, as Charlotte said, we'll build a much wider range that can be taken over and seen there. And if we go on to the next slide. Lovely. So this is the data that we've got so far. 36 patients seen over 15 clinics. We have a really high DNA and cancellation rate, and we see this across the whole eye hospital, something that we're working on a lot. They're booking on average 4 patients per clinic, and we have about 40% DNA rate. So not too many patients seen so far. The clinics currently occur weekly. And it's run alongside the consultant. So the consultant has their own list, but are available to discuss cases. Average age of about 5.3 years, ranging from 6 months up to 15 years. And it's a pretty even split between new patients and follow-ups. And if we click again, we might see the diagnoses. Yeah, so this is just a representation of the diagnoses that have been seen so far. Mostly chalazion is very popular that comes through, the nasolacrimal duct obstruction and allergic conjunctivitis as well. Not very much blepharitis has been seen. And then that 25% of the other category, if we click again, there's just the diagnoses that have been seen in that other. If we go towards the next slide. Yeah, so some things come through. Anisocoria, things, epiblepharon, corneal abrasions, heterochromia, and sort of these things that can be seen, but they come through either by accident or they come through a different way. And the ones that are other, who perhaps come through by mistake, always have consultant input and that sort of thing. And hopefully these are more things that will be able to be seen more independently going forward. If we go on to the next slide. So this is just a slide about the type of management required, and I thought this was interesting. Some of the criticism that I got when I was trying to implement the clinic was that, oh, you're just delaying the appointment with the consultant. Actually, my most common management is discharge, so we are able to safely discharge patients and not just delaying their appointment. Most of them can be treated conservatively, then some pharmacologically, and I'll speak about that a little bit in a moment. 4 patients was observation and 2 were referred for surgical management. We go on to the next slide. So our main challenge at the moment is the pharmacological management. So about 19% of the patients require this management, and as a base professional ophthalmologist, I can't prescribe. And if we go on to the next slide. So these are the drops that have been prescribed in the clinic so far. Steroids, antihistamines, lubricants and antibiotics, and that sort of thing. A couple of drops that I expect to be needed in the future that I just haven't needed to prescribe yet. We're currently working with pharmacy as to how we can proceed with this roadblock, including potentially taking medical exemptions, although that won't allow us to prescribe and only supply. Potentially working alongside a nurse, which would be incredibly valuable, and also hopefully at some point a way that we can independently prescribe. And if we go on to the next slide. So looking ahead in the future, we're looking to expand the cohort to that real sort of breadth paediatric ophthalmology. We'd obviously like to improve attendance, and then we would like to build on patient feedback. So we haven't had any official written feedback. A lot of the feedback that we've got so far is verbal, and it's so far all been positive. The main thing that people appreciate is the speediness of the appointment. So usually if patients are used to coming into our department, they usually spend between 2 and 3 hours. And if I can get them in and out within an hour, they're usually pretty happy. And then the last one is of course overcoming that pharmacy roadblock. And if we go on to the next slide. That's me done. Thank you so much. I'm happy to take questions.
Thank you so much, Christina. And I'm just really conscious of time. That was really interesting. And I'm sure there are lots of questions coming through in the chat as well. But if we could maybe move to because we've got a presentation, a recorded presentation now from Olivia McClelland and Chloe Gerard, who are orthoptists from Manchester Royal Eye Hospital, working alongside SUS, and they're going to explain about the implementation of their clinics. And then hopefully we'll get round to some questions. And if not, we will answer them all at a later stage. Thanks now. Ooh, Helen, don't think we can hear. Is everybody else on mute? Are they?
I can't hear it either.
Is everybody else struggling to hear that? Yeah, I'm getting some nods of people that I can see on the screen. Not quite sure.
We try turning the volume up maybe from when we're playing. Thought I could hear something, but it was really, really faint.
Yeah,
So
I only got
the
a
sound not
snippet.
coming through on the video,
No,
everyone?
No, not at all.
Okay, what we'll do, Veronica, then is what we agreed. We will send the video out to all members after the meeting, and then you can all, listen properly and get the full extent of it. Apologies for that. We did test it and the sound worked, but it doesn't always work on the live meeting, so apologies for that.
No, that's absolutely fine. And that's great. Thank you. I just wonder whether we maybe just take one question before we move on to Amanda's talk, if that's okay. So Louise has actually put in the chat here, have you ever considered working alongside an IP optometrist? I think that question was related to Christina as an option for the prescribing element at the moment, while orthoptists still can't independently prescribe?
Yes, that's something. We do have some optoms working in paediatric ophthalmology. However, it may take the same amount of time going to an ophthalmologist and going to the optometrist. So we're not lacking in availability of consultants. They're very happy to prescribe, and we tend to go to them. Whether we can replace that with an optom, it's not something that we've tried so far. The consultants are usually happy to prescribe. It's more the fact that we'd like to be able to do that prescription without having to go to a separate person.
Okay, that's lovely, thank you. Okay, so just looking at the time, and I think we will take all the other questions and collate them and get some answers back to everybody. But if we could move on, I'm going to hand over to Sunil, who's now going to chair the next part of the meeting.
Thank you. So next up, we have Miss Amanda Churchill, who's a consultant ophthalmologist from the Bristol Eye Hospital. Amanda, thank you very much for joining us today to talk about your experience of innovating in paediatric ophthalmology with regards to video consultations. So I'll just hand over to you now, if that's okay.
Yeah, thank you very much for inviting me. I've been a big advocate of video consultations. It all started obviously during COVID, but and it was my way round not being able to see the patients in the clinic. My practice is mainly, well, it's general paediatrics, so it includes strabismus, but also paediatric cataracts, paediatric glaucoma, and genetic ophthalmology. So I'm just going to talk to you really about the challenges and the successes and the sort of case selection that I use. So who do I use it for? So in my genetic clinic, I use it, and this is mixture of adults and children. I use it for any new cases, for instance, where parents have questions about what is genetic testing, where they don't really need to be examined so much. It's more just a general conversation. Because perhaps their child or the baby already has a clinical diagnosis. When I first started my genetic clinic, it was very much a case of I was phenotyping the children or the adults. But now with all the imaging that we have, a lot of the cases come from my medical retina colleagues. They've already got a diagnosis. So they're really being referred to me for a talk about the genetics, whether genetic testing is right for them, perhaps seeing my counsellor to go through any other questions or be signposted. So all of this actually can be done very well by video and doesn't need them to drive all the way to see us in the clinic, as many of them come from quite a long way around the region. So that's one sort. Then I see people for follow-up. So I may have seen them in the clinic. We may have had a talk about the genetic testing, taken blood, gone through all the consent process, sent the results or the blood off for testing, and then we get the results back several months later, and we want to just talk about that. Again, they don't need to come face to face to see me. This can be done over the video. And one of the advantages, apart from their not having to drive to see us, pay for parking, hang around in the clinic, is that we're also freeing up a room in the department so somebody else can be doing a clinic, because we're very, very strapped for physical space in our clinic, as I'm sure many other people are too. The other thing that I do in the genetic clinic is I often have a sort of annual call-in, particularly with the children, where they're having key educational transitions, maybe going from primary school to secondary school, or maybe even just changing schools, where I just want to check that they're okay, they're adequately supported. Maybe it's for registering them as severely sight impaired or talking about that registration process. So again, it saves them having to come into the clinic and maybe miss school. So the paediatric clinic, the kind of people I see there are pre-op squint discussions when I get referred a patient by the orthoptist and they just want to talk about what does surgery involve. I see my first post-op follow-up by video consultation. So there I'm just I can see adequately from the webcam whether they've got good horizontal, if I've done recess movements. I can look at the wounds, I can talk to them, have they got double vision? So I find it's really, really helpful for that. It avoids them having to come anywhere near an orthoptist, so the orthoptist can get on with seeing their patients. They're literally just seeing me. Had they come in traditionally to see me in the clinic, they would automatically have had had a double slot. So they'd have seen the orthoptist and seen me, and I don't think that's necessary at this particular point following their surgery. I see post-op probings this way, any lumps and bumps, including dermoid cysts, where I usually can discuss the pathology as well at that point. I have used it for where we've had very severe delays or A&E follow-ups. So these might be cases, it's getting less now, but we've had a year delay, 18 months delay, sometimes with COVID, where the child's either completely got better or, to be quite frank, they've probably gone blind. And I'm doing a consultation to find out which category they fit in. And hopefully it's the one where they don't need to see us anyway. And then we can just take them off our list, or we can arrange for a follow-up if they really do need to be seen. So it's a kind of triage service. And then finally, I use it for talking about results. So if they've had imaging done, or if they've had intraocular pressure checks where they've just come in to have literally a pressure clinic that our nurses run, or if they've had electrodiagnostic testing done, then they don't have to hang around again in the clinic for an hour or so to be seen. They can just have the test done, go home, and then I can discuss the imaging with them at another time. And that other time is really efficient, as I'll talk to you about in a minute. So what do I see as the advantages and the disadvantages? Well, I do the clinic from home, so it's great for me because I can do it on a Saturday morning at home. I don't have to drive in, so I have the travel time is taken away. I don't have to pay for parking, which I would normally. So it's great. It provides me with a little bit of additional income. So that's really nice when I'm planning my holidays. And there are hardly any DNAs. So we talk about all the DNAs that we get in the clinic. And I think this is because patients generally like it. It's really convenient for them on the whole. Yes, you will get the odd person that can't work the software. And I have had that, but that's actually really quite few in number because I do select the patients. And if it's a post-op squint, then I'll obviously talk to them when I'm doing the surgery, and I'll say, I'm going to do a video follow-up with you. And I've probably done a pre-op with them anyway by video, so they usually know how to work the software. The appointments always run to time, so I never overrun, and I give the same amount of time for a video call than I would for a face-to-face. I have there's no backlog or delays. It literally depends on how many Saturdays I want to work. And yeah, basically I find it a really satisfactory experience for both me and the patients. The disadvantages are I do need to do a little bit of preparatory work to go through the notes beforehand on the Friday before the Saturday I'm doing it, because we're not allowed obviously to take medical notes out of the hospital. So I need to understand what it is I'm going to discuss with the patients. We do have trust laptops, and I think that's going to be my way forward because we're now moving on to an electronic patient record system, and I'm going to need to access that anyway. So I think that would be something just to factor in, that you probably need to have access remotely from home if you're going to do it at home, or I just come into the hospital. The clinic outcomes and the letters I type myself just straight after so that's actually part of the clinic consultation. And then I email them off to my secretary, and then she can top and tail them onto a trust letter. My only reservation, and I don't think it's happened yet, is that somebody might video it and they might put it on social media and they might go, oh, she was absolutely terrible. So I guess you have to kind of think a little bit about your way of communicating with people. But, you know, hopefully you have a good patient rapport and a good bedside manner in the clinic anyway. And that ought to translate really to your video experience. So what I did, and I'll just very briefly run through this, I wanted to survey people to ask them what their view was. Now, this was an absolute nightmare because I had to go through all the trust committees, and I had to use their way of collating data. I couldn't use like SurveyMonkey or something like that. So everything was really slow in going through. And then I had to use this absolutely awful link here that you can see that I had to put in the letters to people to say, could you type this in? And then it was only part way through that Sunil, I think, and somebody else came up with the idea of why don't we put this QR code into the letters, so to make it a little bit easier for people to access the survey. So I suspect we put people off right at the beginning with not being able to access the survey. But just a very small group that I just want to go through, just to give you an example of kind of comments, really. So I had 13 people respond initially to the survey. 11 of them are women, and 12 out of the 13 were aged between 35 and 54. 5 out of the 13 were new patients, and 8 were follow-ups. So, I asked them the typical questions: could you use the software? Could you see me? And could you hear me all right? And they all said yes. So there you go. This could be a bias selection because they could actually access the survey in the first place. So they're probably software savvy, but they could work the system. Did they feel comfortable? These are more important questions, I think, talking about their child's condition. And only one of them said no, but in a way, I'm glad somebody did say no, because it gives us an opportunity just to look at that in a bit more detail. They all felt included in the decision making, and they all felt there was sufficient time to discuss their concerns. They didn't feel it was rushed in any way. A huge number since this survey have said how beneficial it is because it saved time off school and time off work. So, and in this survey, they all believed that too. Only one didn't want to use the video again, and I think that was the one that wasn't comfortable about talking about their child's condition by video. And 3 out of the 13 felt that it was worse having a video consultation than a face-to-face. And I think, you're always going to have some people who just want to come and see you, and, we have to expect that. Of the free text comments, the ones that were negative or neutral, obviously we had the I feel more comfortable and confident in a face-to-face consultation, no substitute for face-to-face generally, and they've preferred face-to-face rather than a video. So that was 3, but that was far outweighed by the positive comments, which actually I hadn't thought about this one. And what they did was they took the consultation at school on their mobile phone, and they involved the teacher in the consultation, which of course they'd never been able to do face-to-face. They didn't have to take the child out of school. Another one involved a vision support teacher. And so I think there are some benefits there that perhaps we don't really think about. One person commented their child had hospital anxiety, and therefore it's a massive bonus not having to come in to be seen. And then obviously during COVID, they didn't want to risk visiting the hospital. And the final comment there is they felt comfortable using it because they'd already had a face-to-face where the diagnosis had been made, so it was a follow-up. And then this one was basically, it looks quite long, but it's that both parents could come because the husband didn't have to take time off work. They found it difficult during the week because of the nature of their work to take that time off for both of them. And so they found it was ideal. And to be honest, I've had video consultations where the whole family has been sitting in the kitchen in their pajamas having their breakfast, and they really feel quite relaxed about the whole thing. So I think that's another good thing. Right, ooh, here we go. I asked them when they would prefer to have video consultations, and just nudged ahead was the Saturday morning. So did they want it during the day, Monday to Friday, in the evening, or on a Saturday? And the Saturday was slightly more popular. Just the additional verbal comments from the genetics clinic was that they found that if they lived a long way away from Bristol, it was much easier for them, that again, they could have their partner with them on a Saturday. They would have had to have asked somebody to drive them, because remember, these are often severely sight impaired people. So it's even more difficult. It's not just, say, somebody with a sticky eye for their baby, where getting a bus or something would be no problem coming to the hospital. these are people that really struggle actually coming, and particularly when you've got short daylight hours as well. They find it even harder if they're having to leave the hospital and it's dark outside. Another person was a student that was studying away from Bristol, and it meant that they could have a video appointment with me and not have to think, oh, I've got to time my appointment for the holidays. So, you know, I think that we sort of look at always think about the cost and the effectiveness from a cost point of view, but these are real benefits from the patient's point of view as well. I think my advice is choose your patients really carefully. Obviously, there are challenges if you're thinking about orthoptic patients and running an orthoptic clinic with visual acuity testing, and I haven't gone down that route. These are purely carefully triaged patients for the specific situations that I suggested at the beginning. Make sure your background's appropriate. I mean, obviously, I've got a very cluttered background behind me today because I'm in the office at work. You know, you don't want to have maybe family portraits behind you at home. I make sure I've got a very blank wall. You can only do a superficial examination. So, you know, obviously you can't do very detailed sort of corneal examination, but it's amazing what you can do on a webcam, actually, if there's something gross. I think it's absolutely brilliant for discussion, what I call discussion consultations. And it really does save time for everybody, and it does free up a room in the clinic, and it does free up the fact they're not being automatically sent for a nurse to see a nurse for visual acuities, or being grabbed by an orthoptist to have their vision checked, which is sort of a standard that we would do whenever anyone comes in the clinic. So it frees up those health professionals. I think it's ideal for what I call my supportive check-ins for my severely sight impaired individuals. And of course, as I said, it's really good for including other extended family members or other health professionals, even a GP or a vision support teacher. You know, all of those people could join in the consultation, and the family, by including them, are automatically giving their consent and their permission. So I just wanted to thank my secretary and one of our fellows for helping gather the information. And that's it. And I know we're really short on time, so there probably aren't any comments on the floor, but I'm happy to answer anything afterwards if anyone wants to put them in chat.
Thank you, Ms. Churchill. That was extremely useful and interesting. Do you mind if I just ask one question, actually? And, you know, I noted that you said you were doing some of these consultations from home and that the most preferred date and time was actually on a Saturday, just. And I was just wondering, for the experience of other people who might want to do something similar and take some of the learning points that you've made to their own practice, did you have any difficulties with regards to information governance or the trust about actually doing these consultations in your own home and the privacy or confidentiality or governance issues relating to that?
No, as long as I don't take medical notes out of the hospital, that's fine. Obviously, if I was going to access stuff, I can't access any of their records from home. If I had a trust computer, I mean, many people work from home and they do have a trust computer and they can access electronic patient records that way. So I think that's already, there's a precedent set up for that. So no, the answer is no, because I don't have any confidential information outside of the hospital, just in my head.
Well, thank you so much for coming and talking to us today. Really appreciate that.
You're very welcome.
Moving on now to our next speaker. We're really lucky to have Dr. Chanel Smith, who's a Foundation Year 2 doctor working in Lancashire. And prior to her moving to Lancashire, she did a very innovative project looking at how we can use new innovative digital technology to examine children with handheld fundus cameras. So I'm happy to introduce Chanel and I'll hand over to you now.
Hi everyone, thank you so much Sunil for that kind introduction. And thank you so much for Sunil inviting me here, and also for the Ophthalmology Alliance for having me give this presentation. So as Sunil said, I did this project as part of an elective actually at Gloucestershire and Cheltenham Hospital. And I was a 5th year medical student at the time, and I used this as my undergraduate project. So it was based on a handheld non-myodratic fundus camera, and this was used to replace the traditional dilated fundal examination technique in the paediatric ophthalmology setting. So we'll just move into the next slide. So I don't need to tell you guys, but we all know what a squint is. But it's obviously one of the most common ocular conditions of childhood. And while in most children, squint is an isolated abnormality, it can also be the consequence of and associated with a variety of other conditions. So examples of that include retinopathy of prematurity, intracranial tumours, trauma, raised intracranial pressure. Squint may be the first sign of a really serious ocular or systemic disorder, and therefore the possibility of a coexistent or causal systemic pathology cannot be forgotten. And a detailed paediatric assessment has to be undertaken. So for all children with either reduced vision or squint, need to have a dilated fundal exam on a slit lamp, and also assessment of the refractive error to be done by an optometrist. Now, there are a lot of limitations as well to this kind of examination in children specifically. The traditional direct fundoscopy in children requires a dilated pupil, and that can be really time consuming to dilate the pupils. And that's not only inconvenient for the patient and the clinician, but it also is quite uncomfortable for the child and leaves them with blurry vision for the rest of the day. And the traditional direct method is especially difficult to perform in young paediatric patients who are probably less likely to comply with this type of exam. And therefore, these challenges can prevent the identification of significant ocular findings that could be really clinically relevant. So studies have really documented this concern regarding the declining use of fundoscopy exams by varying clinicians in varying specialties. As a foundation doctor now, I know that all my A&E doctors and doctors in other specialties, whether on GP, are really reluctant to perform a fundoscopy exam. And that's a really big problem because it's resulting in a decline in the general diagnostic accuracy. And therefore, a trained ophthalmologist must carry out a fundus exam to ensure successful fundoscopic visualization. And also, an optometrist must be seen to them as well separately to assess their refractive error. So as you can see, this is quite a big problem, but we think we may have found a solution to this. So the next thing I wanted to talk about was the Optomed Aurora camera. So we think this may be the solution. So this Optomed Aurora camera is a non-myodratic digital camera, and it may actually offer a safe alternative to the traditional dilated exam with slit lamp. So the benefits of this camera is that it's handheld, it's portable, compact, and a lightweight instrument, and it's made for the examination documentation of the retina for various eye diseases. It has a new high contrast optical design, and that is used to detect small early change phase retinal changes, and it also provides an increased field of view, which improves the visualization in a non-dilated eye. It also has an autofocus and auto exposure, and that allows really quick usage of the camera without any setting modifications. And it's really well integrated as well into the system in hospital, because not only does it have USBs and it has an iCloud setting, it means that these images can actually be spread really widely with other clinicians as well. And another benefit of this camera is that studies have already shown that non-myodratic, non-fundus cameras have a really high specificity and sensitivity to detect visual changes for things like vision-threatening diabetic retinopathy. So this could actually be used as well in an emergency setting and community outreach settings as well. So moving on to our objective then. So we use this handheld fundus camera in Cheltenham and Gloucester. This is actually me on the left-hand side. So I was just performing this procedure on one of my colleagues, as you can see here. And the University of Bristol at the time, they also asked me to essentially do a vlog of my elective, what I was getting up to. And a lot of people found this really interesting, some of the work I was doing as my undergraduate project. I showed how easy it was. I was a single medical student. I'd been trained using this camera for a single day, and I was able to really successfully obtain really detailed images of the back of the eye in a non-dilated eye as well, which should just show that if I could do it, anyone can as well. And these are just a few examples of some of the photos that I was able to take. And as you can see, this is a really detailed image, considering this is in a non-mydriatic, non-dilated eye. So it just shows basically that the specificity as well, and how this could be incorporated into an emergency setting to really pick up a lot of retinal pathologies. So moving on to the next slide. So just to summarize then, to our knowledge, there's no published study regarding the use of this OptiMed Aurora camera to replace the dilated fundus exam in children to screen for retinal abnormalities. So this technology shows a real promise in helping to improve not only the accuracy and documentation of the fundoscopic examination in outpatient paediatric consultations, but this could really allow non-ophthalmic clinicians to screen for retinopathy and therefore reduce the number of referrals that we're sending to ophthalmologists, and ultimately reduce the pressure on our eye clinics. So regarding methods, so we carried out this study at a single site. So as I said, it was carried out at Gloucestershire and Cheltenham outpatient paediatric eye clinic. And we conducted the study between May and June 2021. And we obtained verbal consent, informed consent from all our patients and their parents as well. And we also gained consent to publish the patient's photographs with the device once they were obtained as well. So in total, we managed to secure 86 images of 86 eyes. And this was from 43 consecutive children who underwent a non-mydriatic fundus photography with our camera. And along with that, we also recorded the age of these patients, their refractive error, if they had any amblyopia, any comorbidities they had, and also any pathologies that they had identified with the camera. All our study participants had undilated images, and then the pupils were then dilated. And one of our senior ophthalmic paediatric specialists with more than 15 years of experience then performed the dilated fundal exam using a slit lamp. And then based on this comprehensive workup, a final diagnosis of retinal pathology was made using the gold standard. And then we compared that to the diagnosis that I used on the camera, and just to see if those two matched up. Just regarding our patient demographics that we managed to secure. So we had 33% that had strabismus, a manifest strabismus. We had 13% that presented with amblyopia. And we also had 15% with underlying conditions that could have affected their compliance with either the camera or the slit lamp, such as learning difficulties, behavioural problems, and things like autism. And just regarding the age range of the children, so as you can see here, this graph essentially shows that the range of children we had ranged from about 9 months all the way up to 17 years of age. And actually, as you can see, the most common age of children that we were able to take photos from was between 4 to 6. And this is relevant just because this matches up with the typical type of age where children will be presenting at school, which really increases the external validity of our study, as this is when most of the children will be presenting with eye problems. They won't be able to see the board at school, or they'll notice that the parents will notice they've got some sort of squint, and this will be the typical population actually that we'll want to be targeting as well in a realistic paediatric outpatient setting. So just to summarise the results then. So in total, we had 43 children had their fundus camera pictures taken between 9 and 17 years of age. Regarding the fundus photography, we were successful in 93% of these children. So only 3 were non-compliant. And actually, the ones that were non-compliant did also have things like cerebral palsy and learning difficulties, and arguably it'd be difficult to take with a normal slit lamp exam as well. Regarding the pathology identified, we showed 100% sensitivity. So any pathology that was picked up on a dilated fundal exam was also be able to be identified on a non-mydriatic fundus photography as well, which is really, really promising as a safe alternative then to the gold standard of a fundus dilated fundal exam. So this just shows some more pictures as well. So these are some of the abnormalities that I managed to pick up using the camera. And as you can see, this is really clear images of things like retinal lesions, macular scars, atrophy around the macula. So it's quite impressive that we're able to obtain these pictures actually without dilating the eye. And all of these will also be able to be detected on a normal gold standard, which just shows the sensitivity and specificity as well. And 23% of those children did actually end up having abnormalities. And then just one other thing I wanted to pick up on that we noticed as well was regarding the refractive error and how difficult it was therefore to use the camera. So as you can see from this table, it just shows where about the refractive error of these children was lying. And as you can see, most children actually had a refractive error of between plus 2.5 and minus 2.5 diopters. So they were basically lying within the middle of this range. And what we found was that these children tended to have poorer fixation. One of the important things with using the camera is to make sure that the child is actually focused on a particular spot within the camera so that the disc is able to be visualized. So for these children who were lying outside of this range, either in the plus 5 diopters or in more than the minus 5 diopters, these patients may be less feasible to be using this camera technique. And next slide, please. And one thing to add as well about that as well, so the fundus camera was actually quicker in 100% of cases as well. So just finally then, just to conclude about the study that we've done, it had a lot of strengths. And one of the main things was that I was able to do this as a medical student with not much training, and that reduces the chance of performance bias. And it also showed that other clinicians who are non-ophthalmically trained may be able to screen for retinopathy. And this actually may be able to be implemented in a remote healthcare setting potentially as well. A single ophthalmologist who was masked from the patient's diagnosis performed the gold standard slit lamp exam, and that in itself reduced the detection bias. I think we can safely conclude that the handheld fundus photography does offer a really safe alternative to the traditional dilated fundal exam. It was subjectively easier and quicker to undertake and doesn't need to be performed by either an optometrist or ophthalmologist. And actually, this mode of examination is particularly suited to the paediatric population, whose pupil size is usually larger than their adult counterparts. And I think further studies would be useful to evaluate the accuracy of this imaging using this camera in a paediatric emergency department and community outreach setting as well. Thank you so much, and I'm happy to take any questions.
Thank you very much, Chanel. That was a really, really great insight. And we do have a couple of questions, but I'm also very conscious of time as well. And I was just wondering, maybe we can respond to those after the meeting, because I believe the meeting finished at 2 and we've still got one more talk to go. So I'm going to hand over to Mina now, if that's okay, who's going to introduce our next guest. And in regards to the question about the camera cost, I can just very quickly answer that. I think it's around £5,000.
Hello everyone, I hope you can hear me. I'd like to introduce one of my own colleagues, Sigrid Wagner, who will be presenting our very interesting work on the automated detection of plus disease and ROP using AI, which we've all been quite excited to be part of. And I'm really pleased to hear that it's now been accepted for publication. So I'll hand over to Ziggy now. Thank you.
Thanks, Mina, and thanks a lot for the invitation to speak at this group. I'll be quite quick because I know we're running short of time. So I'm Siegfried, I'm a PhD student at UCL and I'm an ophthalmology trainee in London as well. And we've been doing some work over the last few years looking at a form of automated detection of plus disease using deep learning. So most people are familiar with retinopathy of prematurity, but if you aren't, this is a disorder of typically affecting low birth weight premature children. It's a sight-threatening condition. One of the hallmarks of ROP is something called plus disease, where you have abnormal dilatation and tortuosity of the retinal blood vessels, and having that feature indicates a high risk of developing sight loss. And so often it's a threshold for treatment. And if you think about things like the WHO screening criteria, ROP is a very good exemplar. We have ways of picking it up at an early stage. We have treatments that prevent it from progressing, and we have tools to identify it. But as one of the main focuses of today has been, there are workforce issues. So even within the US, if you look at studies from about 15 years ago, 30% of neonatologists you survey would say that they'd seen children with severe sight loss because they couldn't find a pediatric ophthalmologist to perform ROP screening, and that's in a high-income country. And then this report came out just last week, so I've added it, showing that they've only got one pediatric ophthalmologist per 3 million people, even in a country like the US. So some people have looked at automated tools, they've looked at telemedicine, and the latest approach, I'd say in the last 3 or 4 years, has been a form of artificial intelligence called deep learning. How does this differ from other forms? Well, it can take high dimensional data, and by high dimensional, I mean it can take imaging data, as opposed to, let's say, an Excel spreadsheet where you have numerical outputs. So there have been a few different reports of artificial intelligence for detecting ROP or plus disease particularly. But one of the challenges is that most of these models are developed in particular environments, the US, Australia, China, and often they don't work very well in populations outside of which they were developed because of various challenges. So you can imagine that many of us use the RetCam, but actually this is a crippling cost in lower middle income countries compared to some other devices. Of course, we know the natural history of retinopathy of prematurity does differ by ethnicity, and we also know AI models can be biased against ethnicity. And then, of course, screening criteria. Who we actually screen differs between countries, and in some countries they have no screening criteria at all. And so that can affect your model behavior. And so we've looked at developing a series of AI models for detecting plus disease, but not just through traditional approaches within the computer science community, but also fully automated approaches. What do I mean by that? I mean that you could train the model yourself, or at least for a focus for us, someone in a low and middle income country who doesn't have computer science expertise could actually train a model for themselves that is optimized on their own local population. And so we had 2 criteria with this study, or 2 objectives. One was to develop a model based on data from an East London hospital, the Homerton Hospital, and to check the performance of that, but also to compare the traditional approaches with those that are what we call code-free and could, for example, be leveraged in low and middle income countries. We took around 7,000 images, which were collected over a 10-year period. This is an institution looked after by Jill Adams, Himanshu Patel, and Shad Hussain as the neonatologist there. We collected all images and disc-centered. They're all acquired on the RetCam. And if you're familiar with East London and the Homerton, you'll know that this is one of the most ethnically diverse and socioeconomically deprived populations in the country. How do you decide whether someone has plus disease or pre-plus disease, especially when you know that most expert pediatric ophthalmologists may not even agree on that? Well, for our data where we developed the model, we used 2 juniors, which I know has its issues, but we had to be pragmatic. When you're grading 7,000 images, it's difficult to get a consultant. We've already talked about workforce issues, so grading images is going to be low on the priority list. But then when we tested the performance of the model, we looked at, we actually got the images graded by 10 separate healthcare professionals, including 4 consultants. And we used a majority grade, so the 3 most senior pediatric ophthalmologists, what did they think was the diagnosis here? We also tested the model on data sets from Egypt, Brazil, and the US, and those diagnoses were all based on both images, but also a full indirect ophthalmoscopy examination. We trained 2 different models, one that is a traditional approach in the computer science group, and one which was the code-free approach. I'm showing the results in a slightly different way to usual. I'm going to show a result, and then I'm going to contextualize it with what we have coming out in the literature right now and what it might mean. So how do we look at the agreement on whether a baby has plus disease, pre-plus disease, or is normal. Well, one measure is you can use something called a kappa, where 1 is perfect agreement and 0 is no agreement. Well, the agreement between our juniors on grading the development data set was about 0.4 to 0.5. Now, that might not sound great, but actually when you look at senior pediatric ophthalmologists who have published many papers in ROP, who've been doing just ROP for 10 or 20 years, even they only get agreements of around 0.4 to 0.6. So actually we found that this was within what has been currently reported. When we looked at the agreement between consultants and everyone for the test set where 10 healthcare professionals had graded the images, actually the grading was quite high. Performance. So often when you go to an AI talk, they just hit you with lots of these curves. What do they actually mean? Well, this is how you discriminate between someone who has ROP or plus disease and someone who doesn't. So for the task of normal, it's distinguishing someone who is normal and someone who has either plus or pre-plus disease. And the closer your curve is to the vertical and the superior lines here, it's a perfect discriminator between the two. Each dot here represents a healthcare professional. For example, this blue one is a consultant, a senior pediatric ophthalmology consultant. This is a pediatric ophthalmology fellow. And you'll see it doesn't exceed the performance, but it gets pretty close to the performance on discriminating between normal and abnormal. The model is not as good at detecting pre-plus, which kind of makes sense, between other, because it's a midway point between plus and normal. And then in plus disease is relatively similar to the normal. As I said, we looked at how it performed across different countries as well. And, you know, in the US, it performs very well. A number of 1 is essentially a perfect discriminator between images with plus disease versus images without. And in general, we found in populations in Brazil and in Egypt, it performed well. Why does it drop down in this one hospital in Egypt? That's because these images are acquired on a different camera, the Forest Healthcare. So that just kind of propagates what we were saying earlier, that these AI models are very sensitive when you take an image from a different device. And that's something we're trying to look at. It's not perfect. It does make mistakes, and we try and be completely transparent about when it makes mistakes. Most of the time, it's that it overcalls things. It says something is plus disease when other people think it might be pre-plus. So, for example, here, many people thought it was pre-plus. One of the models might say plus. There were cases when it might call it pre-plus instead of plus. Those we're not too worried about, I think, because whether you have pre-plus or plus is usually the same follow-up or the same, let's say, clinical management strategies. Where we worry is where the models might think it's normal and other pediatric ophthalmologists might think it's disease. So, for example, here's 3 cases. Poor quality image, perhaps. Maybe they're borderline cases, but, you know, in binary speak, they're wrong in those cases, and we need to look into those a bit more. So that's one thing we're doing in future work. We're looking at how this model might perform in other hospitals across the UK. So, for example, Mr. Biswas, we're collaborating with other groups in London. We're looking at, even if you get an output and it says it's plus disease or pre-plus disease, what does the healthcare professional actually do with that information? So far, research in other areas of clinical AI say that if you're very senior, you don't really care what the AI says. You're going to make your decision no matter what, and it doesn't affect your performance. It's really the juniors where it might help quite a bit. But then there are others, for example, who look at chest X-ray interpretation, and it makes them worse. It makes them second guess themselves when they're actually confident about the diagnosis. So that's something we need to look at before anything like this would ever be implemented. We're looking at synthetic data because, of course, of data privacy issues, and also wanting to share data with low and middle income countries so they can develop their own models. And then we're looking at a couple other things. So, you know, it's fine when you get someone to call an image plus disease, pre-plus, but why don't we try and get something more objective, like actually extracting how tortuous a blood vessel is or how dilated a blood vessel is. We're looking at that, and then we're looking at other things in ways where we can share data in safe methods. Sorry to sound very rushed, but I wanted to get through it in the brief time. And this group, there's a lot of people who contributed to this work, so just to acknowledge their input as well. Thank you. And it's before 2 o'clock, so.
Thank you very much, Ziggy.
That was great. Thank you. That was really, really interesting. I think we are on 2 o'clock, and in the interest of time, I'll try and summarise and wrap up. But I think the first thing I wanted to do was to thank all of our speakers for what has been a really fantastic and thought-provoking session. I hope you would all agree that. I think also we could have talked for hours and hours, and it's generated quite a lot of comments and questions in the chat. Some of them have been answered. Thank you, Charlotte. I know you've been trying to answer as you've been going along as well. What we will do is we will collate those and get some feedback to everybody and come back to people with the answers to those sort of the frequently asked questions there. Obviously, if anybody would like to put in a final comment into the chat, you probably have got about a minute or so to do that. And obviously, I'd like to thank the UKOA for asking us to run this session as well, because I think it has been absolutely brilliant and a hot topic, because it's something that we really want to focus on, given the workforce challenges around the paediatric ophthalmology workforce, particularly at consultant level. So a final thank you to everybody, and again, in particular to Sunil and Mina, who have helped put the session together. So I will wish you all a very happy afternoon, and we will come back to you with those questions very soon. Thanks, everybody.
Thank you.
Bye.